Oh, hey, Chris.
Hey Chuck, how are you?
Fantastic. How are you?
I'm good. It seems like you're probably recovering from what was probably a very busy holiday weekend.
It's funny because we discussed recording this episode last night, which would have been July 5th. And I'm like, I'm too tired. I'm old. I'm recovering. Let's do it this morning, which is early in the morning of July 6th. So Thursday, 2 days after 4th of July. And I woke up so tired that I wasn't sure I made the right decision. I always wake up before my alarm, and then my alarm goes off, and it was one of those, I don't know where I am, I don't know who I am. You know those experiences? It was crazy.
Yes, I'm sure. And I think we're going to talk a little bit about your 4th of July weekend here in St. Louis. We were actually away, and I had a similar experience similar but very different experience yesterday when I woke up in my own bed on Wednesday morning, not knowing exactly where I was because I was so used to sleeping in the bed at at the vacation home we were at in Georgia. So, yes, very different experience, disconcerting nonetheless.
Yeah. So was this just you and your wife, or was the whole family on a
Whole
long weekend?
family, whole family took the weekend off. My wife is, I think I may have mentioned this on the pod in the past, but my wife is on the 50 states with the kids before they're out of the house bend. So, right now, I think that was number 16 that we checked off the list, going to St. Simon's Island off the coast of Georgia. Flew into Jacksonville and drove an hour, and we had a great time. It was really fun.
That counts for Georgia? That is so not Georgia. You're just like, this is by
Oh,
the
oh, it
letter of the
was
law.
it was very Georgia. I tell you that. I'm gonna leave it at that, but it was very Georgia.
Yeah, be careful. I'm an Alabama boy.
It was more Georgia than many would say Atlanta is.
Well, that is true. That is very true. Well, good. I'm glad it was a good trip. I do want to mention I'm on a new kick before I talk about
Yes,
Fourth
what
of
is it?
July. Overnight oats, which I am not new. In fact, I am very late to
It
this
too.
kick. It is so good. I don't know what took me 10 years. It's so good.
It's
It's
probably Jessica Billig rotating on your on your surface with all of her overnight oats that I think Marty Boyer would gently tease her as her mush.
I look, I was looking for a new breakfast that filled me up, and this is awesome. So for all those what is this, socially disconnected people like me, overnight oats is awesome.
So is this like you're one of those guys that does like the batch prep like for the whole week, or you like definitely like set it the night before and then
Yeah, night before, my milk, my chia, my oats, and add a little sweetener in the morning, a little fruit maybe. Ah, my God, it's good stuff.
I will say, as a texture guy, overnight oats has fantastic texture. I just, have never gotten there. Maybe one day, maybe one day.
Well, I realized you hadn't gotten there because I haven't seen it on Instagram. So if it's not on Instagram,
Exactly,
it's,
exactly.
it's not
So
your life.
if there are any overnight oats enthusiasts or overnight oats makers that want to sponsor us, let us know because apparently Chuck is going to be on the take.
At least for the next week, at least.
So how was
Uh,
4th of July call? What is that like? Certainly, as we talked about in maybe a little less lighthearted way on the last episode, we see a lot of ballistic injuries here in St. Louis. This is certainly a ballistic injury of a different sort that is quite seasonal.
yeah, first of all, I like how we do our call. So, in other words, our goal with call on these long weekends is to give everyone, except for the person on call, time to do what they would like with. So, I was on call from June 30th through July 5th, which is great. And being very serious when I say that, because it really does give every other person time. Although Monday was a normal work day, so in quotes, because not much of the department was working. But it's nice, get away. It really is a nice opportunity. So thank goodness for David Wright, who is one of our remarkable fellows, who was incredibly good. We did not get absolutely obliterated with firework trauma, but we had enough to keep it interesting. Um, I have to say, Marty Boyer usually does the 4th of July, or likes to, and he likes all hands on deck, everyone around. It was just a normal call weekend for us, and we didn't no extra fellows were called in. But all firework injuries are kind of the same to me. The pictures look terrible, and the reality is in the OR there's usually not all that much to do. Um, and it's a matter of typically the first web space often gets blown apart. maybe some distal amps, depending on the size of the explosives, and often some burns. Ophthalmology is usually involved before we can go to the OR. So interesting, but we had 3 or 4 of those to a significant degree, and thankfully all came together nicely.
Two things. Classic
Nice,
Chuck manner.
nice.
I thought the first thing you're going to say about how you like how we do call is that we split it with plastics. So that is, but as your partner, I appreciate what you said about how we've done our call schedule. I think much more thought has got into it in recent years in terms of making sure to rotate the calls in a way that works for everybody, and that clearly helps with families and people with young kids. So as your junior partner, I appreciate that. So thank you for taking 4th of July call. My son's birthday is on July 8th. So every year we're typically out of town. I'm sure when I get to my queue every 7 years for 4th of July, it'll be I'll have to tell my son we're staying in town. But my second thing is, asking, does your threshold for replantation change with this kind of injury versus, I don't know, say the standard kind of table saw industrial accident, not an avulsion, but does it change at all over this weekend?
In response to your 2 points, I'll give you 2 back.
Of course.
Yes.
Classic, very on brand.
Yes. Number one, I think these are almost never replantable, and there can be an avulsion type injury, which there certainly was for us in these cases. So one of the patients you actually may be seeing at some point who avulsed, we saved the thumb, but the digital nerves were both avulsed proximally. Not that there's anything you can do for it, but you can be creative. And so I think replants are almost never the situation. I can't think of ever having done a replant in these situations. For me, probably the single most important technical consideration is the first web space. And so if someone's holding the firework, if it's a Roman candle, it's a little bigger. Those usually are more burns than explosions, but obviously our fireworks industry is not regulated, so those can be explosions as well. But the first web space gets blown apart, and I think the temptation is just to close it, get everything closed, close it down. And what happens is you have a markedly contracted first web space and no one's happy. And so we do a lot of pinning of the first web space. I don't think this is particularly novel that we do that, but I think it's really important that we do that. One of our patients had a CMC fracture dislocation, and so we pinned that and the first web space to let the soft tissues heal. So yeah, it's a lot of that just soft tissue work, which is fine, and got to monitor people as they heal.
So I think you're probably downplaying your expertise in this area with regards to the first web space. I've learned a lot from you along the years in how to evaluate and treat that part of the injury. Do you have any technical pearls about the pinning itself, like what size pins to use, how many pins, what's your configuration, and then also in terms of coverage, are you doing any rotational flaps at the time to bring in some local tissue, whether it's pedicled or random pattern, to try and get some kind of tissue in that void, or are you setting things up for later reconstruction?
Thank you, kind words. I would say that no immediate soft tissue, rotational flaps, etc. I'm a big fan of dorsal advancement flaps. That's because of my congenital bias. And if the dorsal soft tissues are unaffected by the blast injury, that certainly can be an effective way to deepen the first web space if it does contract. But honestly, I think if you need skin and support, I think you're looking at either a groin flap or a forearm flap of some variety. So in these cases, it was simply primary closure. And then we'll see what happens. Thankfully, infection, in my experience, has not been a common issue here, but I think we just want to get through the initial trauma and then reevaluate. And as far as penning goes, I go big on these pens, 4 or 5 at a minimum, but typically 6'2". I place my pens proximally at the between the first and second metacarpals. And I think if you place it distally, it just creates more scarring potentially. So proximally, and one of the pearls, and anyone who's done enough hand surgery knows, if you take a 6'2" K-wire and keep firing and keep missing, and I will say it's not easy to go from the first metacarpal to the second metacarpal. It sounds crazy. Even if the wound is open, it can be a tricky thing to do. Similarly, going from the fifth metacarpal to the fourth metacarpal for, say, a fifth CMC fracture dislocation can also be tricky. And you cannot fire and fire and fire, and all of a sudden you've perforated or postage stamped the metacarpal, and it can break later. And I've seen it. So that's the only technical consideration or worry that I have with that technique.
So postage stamp. Many of our younger listeners may have never handled the postage stamp, but I think you're talking about perforations around the entire periphery. Is that correct?
So that was a new term to me when I use postage stamping, the little dots, when I do most of my osteotomies. And so I take a K-wire and I perforate the cortex and then use an osteotome to complete the osteotomy to minimize heat, to maximize healing. But yes, if you're multiply perforating a bone, you weaken it, obviously, and that's the intent when you're performing an osteotomy. It's not the intent when you're performing a pinning. It's funny though, along those lines, we were talking the other day about a bunch of old people were sitting around the table talking about generational gaps, and someone made the motion of rolling down their window with a manual roller. You may not even remember what that looked like.
I remember. Oh yeah, I remember that.
And no one
That's
knows what you're
funny.
talking about. Yep.
But still, people get the thing with the phone when you put your your thumb in your pinky. Even though many people have never held a phone in that way.
That's true. I mean, I don't know that all kids do. Like I asked my kids that very question. It was for me, it was more of this, like, what's this? And it was kind of like, well, are you holding your fist up to me?
See, those of you that are only listening on audio and are missing the YouTube feed are missing all these wonderful gestures that Chuck is making, as well as him scarfing down these overnight oats. Before we move on, I want to ask you, so it's two pins, are they largely oriented in a transverse manner?
Yes.
And then how do you position the thumb in terms of where it is relative to the plane of the palm?
Yeah. So I prefer, well, I think anteposition with maximum radial and palmar abduction is one way to do it. And certainly that's appropriate. I don't mind if it's just radially abducted either. So in the plane of the fingers, I think is okay. As long as we're putting the skin on tension, and you actually put it a little more tension, I think, when you're maximally radially abducted.
And I think one point that you mentioned, and should be reinforced, is the importance of debridement. I think getting a really good debridement, or as Marty would say, debridement, is critical with this because I think the last thing we want to do is leave a nidus for infection. And unfortunately, a lot of my experience with firework injuries is that not all of them have the ability to follow up locally, since given the nature of our center, we see a lot of people that are transported in, sometimes unnecessarily flown in for revision amputation, because nobody knows what to do with these, and they're very intimidating based on the pictures, as you alluded to. Everybody has this kind of shock factor. I remember 4th of July as a fellow, just having a nice day, and then it started like in the late afternoon, and I got to the hospital. I hope nobody from the ACGME is listening, but I didn't leave the hospital for a solid 30 hours just because there was so much work to do. And so we had to, it was just a busy time, but there were a lot of transfer calls, and triaging those can be challenging because it's very intimidating. If you're already we were doing some microvascular work at that time, and whether to accept something when you're already doing a micro case is one thing, and that's probably a topic for another day. But then also just moving through the line of revision amputations, trying to figure out what could be done in the ED, what needed to be done in the ER because of the debridements, all that kind of stuff.
Yeah, all really good points. And it goes back to your previous question slash point you made about, what do you do immediately versus what do you do in a delayed fashion? And, we want to do the right thing for the patient, but a patient who has trouble traveling and may not be able to come back for follow-ups in St. Louis, that's a real trick. And should we be more aggressive with immediate flaps if potentially necessary? And it's a fair question. I don't think there's a right or wrong answer personally.
Absolutely. And we should have an episode at some point about, non-microsurgical flaps that hand surgeons can do, including that growing flap, which is a nice technique to pull out of the bag every now and then. Certainly one that is a little bit of a shock to patients if they wake up with their hands sewn to their crotch. But we should talk about that another day. I'm sure there are a lot of guests we could have on to talk about that. We
Yeah.
should thank our sponsors.
Absolutely. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand. So I wanted to thank all the listeners for writing in. We've had some fantastic emails come in about prior episodes, a lot about the FPL reconstruction episode, great pointers. I do want to save those for another episode. We've had a great email about our scaphoid discussion from our last episode with a little bit of a contention, which is great, good to discuss. So I think there's a lot of good stuff in there, and there's a nice PIP case. So we'll save those for another day. But I do want to thank everybody for writing in. We get the emails, we love it. It gives us great stuff to talk about. So if you have any questions, suggestions, cases, etc., handpodcast@gmail.com.
Yes, love it, and really, it's so helpful to have that fodder for discussion because it means that people are interested and engaged, and there's really good topics. And yes, you and I had to discuss this morning. Where do we start? But we're starting with a little journal club.
Yes, we did talk at the end of the last episode about how we wanted to do journals, but we got kind of caught up in that scaphoid case. So speaking of scaphoids, there was a really interesting article from the Machine Learning Consortium, which is all over the place, but really headquartered in the Netherlands and in Australia. So machine learning for scaphoid fractures. So there's always that clinical conundrum about the occult scaphoid fracture. And the first article, or the first author on this article, was the last name Bulstra, and this was in the Journal of Hand Surgery, the American edition, last month. So Chuck, what did you take home from this? I mean, they looked at 117 fractures that were confirmed on CT scan, MRI, and on X-ray, among 422 patients with radial wrist pain after a wrist-sided trauma, and then use machine learning algorithms, which they did not disclose the algorithms because I think they're still being refined, so to say. But interestingly enough, I think they're getting closer to trying to find some kind of decision aid for the occult scaphoid fracture.
Yeah, and you and I have discussed on the pod how we each approach these in the sense that, when do you immobilize, when do you get advanced imaging, et cetera, et cetera. So the point of this study is, can we accurately predict the probability of a fracture, and can we decrease the number of patients who have advanced imaging to rule out a scaphoid fracture? And I have to say, I don't know that in any way this changes our current treatment. It has the potential to change our future treatment, but it is pertinent because machine learning is all over the place. And I think this is coming as an adjunct to our clinical acumen, and it will make all of us a little bit better because this just makes every decision a little more scientific, or I should say, it will make every decision a little more scientific. That's really what, I hate to simplify the message, but that was my takeaway. What about you?
Yeah, no, I think it's interesting because, when I think of machine learning in this context, I think about, a lot has been said about the potential for machine learning and quote AI in a very kind of broad term about replacing radiologists in many ways in terms of pattern recognition on imaging. So this I think is interesting because it goes beyond just the radiographs and looks at some of the clinical factors, in terms of locations of tenderness, age, mechanism of injury, that kind of thing, and factors in essentially doing a modern version of something like the Ottawa ankle rules, like, the rules for like a decision, simple score for like if you come in with ankle pain and whether you have an ankle sprain, whether you should get x-rays or not to look for a fracture. Now, clearly, sending somebody for a CT scan or an MRI, one of the advanced imaging modalities is much bigger deal than getting x-rays. So this algorithm was able to cut down, it had 100% sensitivity, although, which is good because it didn't miss a fracture, but it probably overcalled some because their specificity was quite low. And they said that they were able to cut down advanced imaging by 36%. So within the confines of a system in which you have finite resources, which all healthcare systems do, and we're trying to be good stewards of this, this has the potential to really help cut costs and drive value. The discussion that we had in our hand service conference on Journal Club was really derived around where is machine learning going to go. And I think what's going to happen is that you're going to see some of these, machine learning algorithms get in the hands of insurance companies and payers. and really drive, the prior authorization process essentially. And I think that can be a bit, I worry about where that's going to go.
Yeah, I think that's well said. And the other factor is, what mattered to their algorithm, to their the ability of the machine learning algorithm to predict things, and male sex. They previously talked about sex and age and mechanism and areas of tenderness, and so I think they did a good job of trying to simplify the number of factors that actually mattered. So I think, look, we're going to see a lot more of this, as we should, and it is going to affect how we care for patients. I don't think it's there yet, but it's not far away.
I envision one day, with some kind of intake form and use of EMRs. So, their figure, that they show, figure 2, in terms of, typing in all the factors and then getting your risk of a scaphoid fracture, is super interesting. It's kind of like, this may have been past your training, but when we used a FRAX score for osteoporotic fractures, and you would go on a website and you would type in all the demographics and you would tell the patient their risk for a fragility fracture in the next 5 years. Super useful for counseling. So you could type all the factors in for this patient and say, look, your risk of having a scaphoid fracture is not 0, but it's only 20 something percent. So I think us getting imaging at this point is probably, advanced imaging is probably overkill. But if your number meets a certain threshold, 70, 80%, let's go ahead and get the advanced imaging, because the numbers show that there's a good chance that the fracture's there. Some would argue, why don't you just treat the fracture if it's radiographically occult by just go ahead and putting it in a cast?
Yeah, it's really interesting to think about this, and one of the reasons you and I wanted to discuss this article is how it impacts our clinical care. Again, today, not really. When does tomorrow begin? I don't know, but is this going to be something else we have to pay for as clinicians or as hospital systems, to access to these machine learning algorithms? And it's really going to be fascinating to see how it plays out. And all I can say is I hope that many of us get involved in this type of research, because I think that will speed the process, but also make it more accessible to all, I would predict.
Certainly agree. I think it's something that, AI is coming in all facets of our lives. You might as well, you either push the elephant or you ride the elephant. It's one or the other.
I did read this morning that access to like Chat GPT is down like 50% since it first popped on the scene. And the cynicals say that's just because it's summer and students are not using Chat GPT for their essays. But I think some of the excitement, of course, wears off. But this isn't going anywhere.
I read, one of the podcasts I listen to semi regularly is The Daily, from the New York Times. And some of the topics, I mean, they cover stuff incredibly well. And I was drawn to the one recently on ChatGPT, which I think is fantastic. And it talks about how students are using it. Some using it for very obvious ways in terms of generating a paper, some using it in a very interesting way to do kind of background research and then write on their own, or using it in, oh, that doesn't sound like what I would write. ChatGPT, here's something that I wrote. Make this sound like me. And then they also give the perspective of a professor, kind of a liberal arts professor, who just talks about how it's sad how, his students don't want to write and engage in the same way that he wants them to, but realizing that ChatGPT is here to stay, and this kind of thing is going to be something we have to deal with. It'll be super interesting to see what kind of orthopedic residency essays ChatGPT generates in the next few years. I think that it's coming, and I think we need to be fully aware, because as we all know, the there are very few personal statements that stand out. You want to stand out in the right way, but for most people, it's okay to just have a very average statement.
Yes, that is true, and I think there are those who can allegedly detect, and tools that can help you detect an AI generated essay or personal statement, but certainly you and I don't have that skill set, I don't think. We may detect if something feels weird about an essay, but we're not going to be able to say that's
Mm-mm.
generated by
I
AI.
guarantee you one of us has read an AI generated thing at some point in the last year, whether it's an essay for one of our programs or even a paper. It's interesting, in the last few months now, for each journal I've submitted to, that you have to submit an affirmation that this was not generated by ChatGPT. So the game has changed, and it will forever be changed. Why don't we move on? Maybe squeeze in one or two more articles. I'll let you pick. I thought the distal radius one was interesting. I also thought the ulnar wrist pain one was interesting too. So where do you want to go next?
Let's do those two. So the distal radius paper, first author is Schmidt. It's based out of various hospitals in Sweden. It's a prospective 1-year follow-up study of 366 patients, managed either with reduction and cast immobilization or surgical intervention. And we can talk about what surgery means. And they looked at a variety of different outcome measures, including radiographs, quick dash, range of motion, grip strength, etc. And
Before you get
basically,
too far, this was in the May 12th, 2023 edition of the American Journal of Bone and Joint Surgery. So JBJS 2023 May, if those following at home.
yes, perfect, perfect. Thank you. And you know, I guess I would say not surprisingly, but demonstrated in a nice way. They really showed, to cut to the crux, and we can again elaborate as you wish. Clinical outcomes declined starting at 5 degrees of dorsal tilt, but really it's not until you get to 20 degrees of dorsal tilt that things really started to matter. So that's my simplistic takeaway. I'm sure you can add some nice flavor to that.
Well, I mean, I think that, any of these prospective cohort studies are, incredibly difficult to do, take a lot of work. Both you and I are living this right now with our different prospective cohort slash, aka registry type studies, which not really registries, but, it's some of those things where a ton of work goes into it, and you kind of have to see where the takes you, even though you have your a priori set kind of hypotheses. So a lot of effort goes into this kind of thing. I struggle with, these continuing, distal radius fracture papers. We saw such a rush of it, in the last decade of, do you operate, do you not operate, what kind of surgery, that kind of thing. And the pendulum keeps swinging back and forth in terms of non-operative management. One of our partners, is quote, aggressively non-operative, as one of our residents described, for treating these. And I think others have a lower threshold to offer surgery. I try to give patients, data-driven counseling based on kind of age, displacement, and what to expect. And this lines up very well with, the work that, the McQueen group has done in the UK in terms of, you look at displacement, and it's stuff like grip strength and the dash that starts to fall off as you get more dorsal displacement.
Yeah, all well said. Again, another golden opportunity for AI or machine learning to help us, because we bring our own biases to this decision-making process. And Lindley and others are working on decision aids, which really will help, because it's really not only about our perspective on what we can expect from a patient-focused outcome. It's also about what the patient wants, what their thoughts are on surgery, what their thoughts are on the aesthetics, because that matters a lot to some people. And in a perfect world, we wouldn't think about that kind of stuff. We would just do the best thing for the patient, but all of it matters. And so this is a really good paper. This will allow us to counsel patients more appropriately, or at least I believe it will for me. But it doesn't fundamentally change the way I think about things. It does reinforce how I think about things. It doesn't change it.
This, I think, reinforces a lot of the work that's already been out there. It's important to have it out there. It's not completely novel, but it's important to demonstrate it. Certainly, I think there are differences in terms of acceptability among different cultures, but it's hard to argue with grip strength and the dash, to be honest with you. I think that translates pretty well across cultures. The article that we covered in our journal club that we're not going to get to discuss today was out of Rochester and Warren Hammert's group before he left there. And it was interesting looking at kind of how they evaluated patient preferences, essentially. I think one thing that, where this could go eventually is, the personalized medicine aspect, and, having having some kind of system where the computer knows your preferences, your personality, and says, okay, well, Chris is really interested in getting back to X, Y, and Z, and based on his fracture displacement and his timeline, he should have surgery, or he shouldn't. So I think that that's probably where it's going to go, but I think the patient preferences and the counseling are key, because every patient is different in terms of what they want, what matters to them. I had somebody who I treated with, with cast management for a distal radius fracture, and her displacement is completely acceptable radiographically. And I told her about the likelihood of having a prominence of her ulnar head, the quote bump on the pinky side of your wrist. It's most likely going to be there. It's not going to change. It's going to be like that. And at every follow-up visit, that is what this patient fixates on. And I said, I could break your wrist again, and we can put a plate on there and make that better, or we can cut out that bone. And that, of course, is unacceptable to them, but they don't like the fact they've got a bump on the wrist. So again, like you said, I think it's all the rub is in the counseling. And I don't think a computer is going to counsel patients for us, but I think a computer can provide a data-driven approach, which will help the right patient.
Yeah, really well said. And the gap between the counseling that we do and not what patients hear, but how they incorporate what we say into the way they think about their issue is really super interesting. And again, every patient does it differently. And I have that same patient that you do that we've had the discussion 10 times, but it doesn't change their perseverating on the particular issue, which was predictable.
Right, right. So yeah, why don't we move on to our final article? I think this one marries our two interests. So this is one, the first article is, the first author is Scott Loewenstein. This is ulnar wrist denervation, articular branching pattern, selective blockade of the dorsal branch of the ulnar nerve. This came out of, consortium of places, really out of Wisconsin, but I know this concept has been really driven by Dr. Lee Dellen, who has been on our podcast before, and his academic appointment is at Johns Hopkins, although I know he is recently retired. And Lee did discuss this with me, when I visited with him when we had our interview. So super interesting article about ulnar wrist denervation. I think the anatomically, they described kind of the pattern of innervation on the ulnar side of the wrist. And then did a simulated block with staining of that would simulate kind of where lidocaine would go and how often that would affect selectively hit the ulnar articular branches and not affect the sensory or motor components of the ulnar nerve. So I think this is interesting because it's not novel in terms of the anatomy. It's not novel in terms of doing a block, but the way that they did this, they wrote this paper very well in terms of positioning it for so that somebody would be interested in reading it. So I think there's a bit of a gamesmanship. That's probably not the right term anymore. Gamespersonship in terms of how to write this article and to get a paper published.
Yeah, there's a lot of different ways to go with it. I like how you said that last piece about there's not a lot of new information here, but it was packaged in a way that is interesting. And when I have papers that maybe aren't accepted to the first journal I submit them to, and the reviewers make comments, sometimes I wonder how I could have packaged the information differently. And this is just well done, right? It is interesting. I am glad to have read it. From the technical message, there's nothing new here, but it does make me think about things. So would you consider using the information provided in this manuscript for potentially considering a denervation procedure for the ulnar side of the wrist, especially focused on that dorsal sensory branch?
Yeah, 100%, for sure. And when I think both of us, just to make it very clear, when both of us make the comments about packaging of this article, we're not saying that in a negative way. I think that's just reality of getting an article into a journal and doing a project that's interesting. Maybe not necessarily novel, but the way you package it is how people are going to interpret and incorporate into their clinical practice. So the way this is packaged made me say, I think this is something I could be interested in doing. And I have had that thought in the past, but reading it kind of makes me feel better about doing it.
Yeah, definitely not in a negative light, honestly, in a very positive light, because I don't think anyone's doing anything inappropriate. They're just presenting the information in a way that will be most, attention grabbing. We talk about that specific thing all the time when we're submitting abstracts for podium presentation, because for those of you who haven't gone down this road before, if you are a reviewer for a major meeting, you are often reviewing at a minimum 50 and sometimes hundreds of abstracts, depending on your role in the process, to decide what is accepted for podium presentation, what might be accepted for poster presentation, and what might be rejected. And you have a short amount of space to make your case that you have interesting, compelling information. And we talk about packaging it all the time in that process. We talk about it less for actual scientific manuscripts, but it's the same process. So I admire what they've done here. And it did grab me. Absolutely. Now, I don't know if I would do it. Help me understand one thing. If the dorsal sensory branch of the ulnar nerve is potentially a causalgic nerve or a nerve that leads to pain if injured, how can you just cut it and expect that the wrist pain will go away and there won't be any nerve mediated pain?
It's a great question. So you need to be very selective in which portion that you cut. So they were very clear not to get the sensory component that went to the dorsal ulnar side of the hand. So that's the causalgic nerve that we're always looking for when we do, any approach to the ulnar side of the wrist as you get towards the ulnocarpal region, just because of what, the paper that Ryan Calfee wrote, which was cited by many, including at the Palma Sharonis graduation ceremony. Which, as a quick aside, I will say I acknowledged on the last episode how honored I was to join the group that got it, and I realized that you also received it. I thought you had, but I didn't want to give it to you if it. But yes, in trying to Google about what honestly the award was and what it means, your name came up repeatedly. So congrats to you on your Palma Sharonis Resident Education and Mentoring Award. But getting back to discussion. So yeah, you have to be sure that you're going just for these articular branches and not for the sensory component, the causalgic component. So I think that that's where the rub is. But the idea here is that what you can do in the clinic, either clinically, which and many people, the more they're more slender, you can actually palpate or roll that nerve, as it's just proximal to the ulnar neck, and block that nerve. And now clearly you're going to get sensory loss on the dorsal ulnar aspect of the hand, probably not on the ulnar sensory distribution proper to the ring and small finger, and you shouldn't get an ulnar motor block. But just blocking that nerve, if it helps with their ulnar-sided wrist pain, that's, I think, the point of this article. It says that patient would be a good candidate for denervation, in which in the actual surgery, you would go for the articular branches alone and leave that dorsal ulnar sensory branch otherwise alone.
Yeah, that was my attempt at a softball for you to hit out of the park, which I think you did. And you're right. I mean, just to be, again, really clear, which I think you were, I take great care. I mean, every arthroscopy potentially puts that nerve at risk. And there's often a transverse branch that goes right near my 6R portal that we really don't want to injure. So it's just those articular branches that we don't really talk about that are the goal here if you were to consider a selective denervation.
Right, and I'm not an arthroscopist, but I stay away from doing 6U for this exact reason of trying to avoid damaging that causalgic nerve. And I think that's why many of us novice arthroscopists will do 6R as opposed to going more ulnar. Because once you, as Ryan showed us, once you get more towards that mid-axial portion of the ulnar side of the wrist, that's when you're putting the sensory component at risk. I think this is interesting. I think that, my concerns still remain with denervation in terms of the proprioceptive loss. I think Elizabeth Hoggard's group has done a lot of work on that. I struggle with, the huge upside is that if you block a patient and they do well with this, and then you do a denervation and they do well, they're really happy because you've spared them a surgery, a different kind of surgery that probably has a longer recovery. Particularly like the total wrist denervations that the Mayo Group has published about, for it's done really well for slack and snack wrists. It lasts them a certain period of time. It buys them time before they have to have a more palliative or salvage type surgery. The question is your patient the right one who's going to be happy with, wow, it's great. That got me a year or two before I had to have X, Y, and Z procedure with a 3-month recovery.
Right. And then what's the effect of the previous denervation on the recovery and ultimate function after that secondary procedure? That's the question. I totally agree. And that's why I'm not early to jump on the denervation option. But again, we clearly don't have the answer to all the problems. And sometimes our options for patients to consider for big risk problems are big risk surgeries, which are not always exciting for patients to hear. So this kind of work is again very, very important, as much as I hate to praise nerve surgery studies.
Well, this is the nerve harming surgery part of it, where you're just going after the denervation. So I think it's interesting. I think it certainly has already influenced how I talk to patients. I've talked to patients about using this kind of approach, and some people are really gung ho about it. I think it's all about again, patient selection, which is a very catch-all term. But honestly, it's probably one of the harder parts of our job.
Absolutely. All right, I'm off. Politicization on the books today, which is exciting. I have another super interesting case as well on a kid that came up from Central America. So good day.
All right. Well, you have a lot of work to do. I've got some abstract writing to do, and then I've got nerve clinic. So we have very different days, but I'm going to go package things very well for this ASPN abstract deadline.
Awesome. Have a good day.
See you later.